time to move on to the next session of the day. And with that, I also promise there are many more exciting games that I'm going to be hosting, and I'm going to make sure that I'll take you back to your school and college times, because as we come here together, while it is about knowledge sharing, learning, transforming, it is also about having some fun. Because as I mentioned, Fluxx is about energy, and energy forces you to live the very moment you are at. But that is going to be happening a little while later. At the moment, we proceed with the next session of the day, which happens to be a panel discussion, and it is going to shed some light on the role of personalized medicine in the future of healthcare. Personalized medicine is not just about treating illness. It's about tailoring care to the individual using science, technology, and data to provide the right treatment at the right time for the right patient. It represents the future of precision, compassion, and effectiveness in healthcare delivery. And to take us through this crucial subject, we have got our distinguished panel who have joined us today. Ladies and gentlemen, with a huge round of applause, please help me welcome Talal Abdulrahman Alzaharani, all the way from Saudi Arabia. Well, the Group Manager of Surgical Operations Services at Eastern Health Cluster, a visionary leader transforming surgical services across 17 hospitals in the Eastern region. Talal has driven innovation in surgical efficiency, patient outcomes, and operational performance, setting new benchmarks for quality and safety. Give it up for Talal Abdulrahman Alzaharani. Ladies and gentlemen, joining this esteemed panel, we have also got with us the Group CEO of Ashkan Qatar and Acro UAE. With 34 years of global experience, Dr. Manoj Menon is a pioneer at the intersection of healthcare and artificial intelligence. He has held senior roles with HP, GE Imaging, and Boston Medical Center, and continues to shape the region's healthcare landscape with AI-driven solutions that enhance efficiency and elevate patient care. Give it up for Dr. Manoj Menon. Everybody, come on guys, keep it going. Ladies and gentlemen, joining this esteemed panel, we have also got with us Maryam Mohamed AlQaseer, the Vice President of Quality and Performance at Eastern Health Cluster. A consultant cardiologist and transformational leader, Maryam has been at the forefront of national healthcare reforms, focusing on person-centered and value-based care. Her leadership has consistently advanced clinical governance, healthcare transformation, and strategic planning across the kingdom. Please give it up for Maryam Mohamed AlQaseer. Everybody, come on guys. Well, and finally, we have got with us the Director of Sleep Care Clinics, Professor Dr. Carlos Rivas Echeverria, all the way from United Kingdom. A global pioneer in sleep medicine, Professor Carlos has led groundbreaking initiatives such as preeclampsia prevention program and traffic accident prevention campaigns in Venezuela. Through sleep care clinics, he has expanded innovative treatment access internationally while pushing the boundaries of AI in medicine. Ladies and gentlemen, we are joined today by the exceptional leaders, and I'm pretty sure they're all set and ready to transform the future of global healthcare. Gentlemen, lady, the floor is yours.
So, Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. It gives me a great deal of pleasure to be moderating this rather challenging panel discussion. It's entitled The Role of Personalized Medicine in the Future of Healthcare, and we have our esteemed leaders and panelists with us, Mr. Talal, Dr. Manoj, and Prof. Carlos. So the topic of personalized medicine and the future of healthcare is extremely trendy, topical, and challenging. And there is a lot of traction in the field when it comes down to this particular topic. However, there are a lot of skeptics amongst us thinking that this specific topic is rather futuristic. So I'm going to be asking a few questions. Some of them are going to be healthcare related, some of them are going to be more technical for Dr. Manoj, and hopefully we're going to be enticing a rather interesting discussion. So moving from theory to, actually I'll start off with Prof. Carlos. Moving from theory and abstract into actual bedside benchmark implementation of personalized medicine. Do we have any live examples of where we've actually implemented personalized medicine? And maybe a follow-on on that is, if yes, where? And if not, or if there is, where do you think the implementation and the breakthrough of personalized medicine will happen in the next upcoming decade?
Well, in fact, it's indeed challenging because nowadays the healthcare systems wants doctors to follow pathways and protocols and very strict guidance. And we are not treating conditions, we are treating patients.
Absolutely.
Is your mom in that pathway, in that spot? Is that the case, your daughter? So we are indeed, in this panel, talking what our pediatrician did on us to treat a patient, personalizing their care. And that's what we need to do. Yes, there are very interesting examples. Artificial intelligence has changed dramatically how accessible is, for instance, to have an ophthalmologist to diagnose and screen retinopathy, diabetic retinopathy. And it wouldn't be possible without that input. The same happened with X-rays. They can detect very precisely and widely tuberculosis, for instance. And my field, sleep medicine, it is impossible, absolutely impossible. One doctor spent 4 hours reading a sleep study that the artificial intelligence is doing for seconds, and I can get the result from Venezuela to my phone.
Absolutely. What about you, Dr. Talal? You're also involved in surgical operations and heavily involved in healthcare. Do you see any implementation of personalized medicine today? And if not, where do you project it going in the future as well?
Okay. Sure. Firstly, good morning, everyone. Assalamu alaikum wa rahmatullahi wa barakatuh. I believe that personal medicine can be works well with the surgical patient. So we have our anesthesiologist and the surgeon who can determine the pain assessment. So as our body that has a lot of genes, so we can select what genes can be examined for relieve the pain. As we know that personal medicine is focusing now in the oncology. However, there is a lot of area that personal medicine can work well with that. For example, the rare disease, cardiology, as Dr. Maryam is the cardiologist, as well some of the, for example, for the cardiologist, the people when they give the test for the familial hypercholesterolemia. So when we select good genes and give a right personal medicine for the patient, even when they are as a post-op in recovery or in the patient can be help them to release the pain and can come with a great outcome there.
What about you, Dr. Manoj?
I think one more area is pharmacology. I think that's some of the area which it's more of commercial thing, so it's a lot of money is going in there. So yes, I think that is the area where people are focusing so that they can put a very personalized drug therapy which can happen. So that is one area which most of the commercial, all the giants like Pfizer's, J&J's, they are focusing on that.
Absolutely. And I mean, from a cardiology perspective, I mean, I can't ignore myself as a cardiologist. There's a huge amount of advances that have happened in personalized medicine. Part of it has to do with genomics, but the other part has to do with wearable devices. So patients now come in and they tell us what's their heart rate trends, what are their blood pressure trends, and from that you can actually, between that and between genomics and understanding the patient's lifestyles, you can personalize the treatment modality to best fit what the patient needs as well. So there is a lot that's happening today, and I agree with you, oncology, maybe cardiology and pharmacology are the future way forward as well. Now, moving away from the implementation side of things, and maybe Dr. Manoj, we're going to be tackling more the technical component. Dr. Manoj is a group CEO of a technical company that has two arms, both in Qatar and in UAE, Ashcon and Acro. We want to ask you, looking ahead, what do you see as the biggest scientific or systemic breakthrough that could accelerate widespread acceleration of personalized healthcare in the future? Where are we going from a technical side?
I wish we had a button to press and personalized medicine. I think one single most thing, multi-omics. When I talk about multi-omics, you have genomics, what you said. Then you have proteomics.
Yeah.
Then you have metabolic
disease, yes.
So, I think when you compare different biological layers, which is important to really have a personalized medicine. So that component is, there are research going on, but it's all in silos. So that is where that essay of, omics, multi-omics essay profiling has to be done. That's one part of it. And then the second part, really to make a difference, the clinician has to go through the clinical data, rightly said, wearable, and I would like to add the lifestyle. So if these three components with the multi-omics, if it comes in one single dashboard, and that's where clinicians will know how to treat this patient. I think that is something very important which has to be taken care of. Now, there are other challenges which is there, and there are some breakthroughs which is happening here. So one, from the point of view of how well the biomarkers are there, I think that's another challenge. From the technology point of view, if I say AI models, that's so many AI models is there. How hallucinated it is.
Yeah.
I think that's where a lot of research is going on to, I think it'll take a year or two because of the Gen AI, the way it is going. But that is another area which has to be focused. And you asked me about the systematic. I think there is a regulatory body for the data governance is a very important factor, which has to come for the patients.
Absolutely.
Which is not, yes, there are, if you really see the genomic studies which is going on, it's all initiated by the governments, whether you take Finland, whether even Qatar doing it, in England it is there, Sweden it is there, Denmark. So everywhere it is initiated by the government because it will take time to get into the commercial stage. So the one last important thing is the stakeholder of insurance.
Absolutely.
Even if that also is included, and that's where it can go to from the pilot care to standard care.
Absolutely. And maybe, Prof. Carlos, I wanted to ask you, going from that technical side of things, are you finding it difficult to collaborate with technical vendors to come up with personalized medicine solution? Do you think that's the future? Would you like to do that? Are there any barriers, regulatory? I know you're practicing predominantly in the NHS system, or in England and in Europe. So are there any major challenges when it comes down to that?
Very interesting, because actually I work also in Latin America.
In Latin America.
Yeah, so we are working in different countries, in different
continents,
in different states, with different laws,
absolutely,
each one of them. And I love the blue ocean strategies. We need to get involved even with our competitors. Actually, I met a doctor from Spain today, and we are going to work together, because that's what we need to do. We need to, all the way up and down, from the stakeholder to the patients, to get the connections. to be able to help and offer the best care possible.
Yeah, absolutely. I totally agree. Now, digital twinning sounds to be like something from Back to the Future, if any one of you have watched this movie. I mean, at least I work in the Kingdom of Saudi Arabia, and His Excellency, the Minister of Health, launched this whole initiative on having a digital twin a couple of years back. My question maybe to you, Dr. Manoj, is how do digital twins fit into the whole personalized healthcare picture?
Oh, that's a great question. As I was talking about multi-omics, and if you have that biological layer with the lifestyle and wearable devices data, and this has to be a continuous information flow to the database. In that case, what happens is any changes which is happening in human, that digital twin will have. So it's a replica of human which is created in the system. And many benefits are there. You can have a targeted treatment plan because one size doesn't fit everywhere.
Yes, absolutely.
So how the body is going to react, how the disease is going to get into a stage where get worse. So you can start predicting on that. The treatment plan can be so precise, and especially when it comes to the oncology, that's the reason why most of the focus is in oncology, because oncology, the way the radiation and all that is there, yes, should be so precise. So digital twin will really give you a better care and better outcome. So the planning can be done on the system. So it's like a simulation.
Simulation, yeah.
So you know how this is going to be, how the outcome will be. So that is going to be the trend. And when you say digital twin, there are many other factors which comes in. I think we generally in IT world, we loosely use this word as digital twin. But it's not social media creating that. It's much more than when it comes to the healthcare part.
Yeah, absolutely. The back end of things in terms of the technical is probably quite complex. I know at least there is amongst healthcare providers, at least I was one of them, and I might still be one of them. There is an element of mistrust in AI, fear of AI, not knowing what happens in the back end that produces those results. And so these are real concerns for physicians, for healthcare providers, and they're very much skeptical on AI-driven insights. So I'll start off with you again, Dr. Manoj, because you probably understand the back end of this, but or what we call the black box. What steps are required to build trust so that AI becomes a reliable partner in personalizing care rather than being that black box tool? And maybe then we can follow up with our clinicians.
So what we called as a black box anxiety.
Yes.
So this is not just in healthcare, it's in different domains, especially the stage what we are in AI. I think most of the people have used the ChatGPT, the hallucination. I think that's where the biggest worry is. Now, to really come out of this, there are 2-3 things which is very important. One is the transparency. Second is the validity or validation of data. And third, most important, is the shared governance. Now, if you talk about transparency, what does transparency mean? Now, if you are treating a patient, you need to, and it's with the AI, AI can generate certain information, but that information has to correlate with data what you have given.
Yes.
First thing. And the second most important thing is needs a reference where this data has been pulled from. And that becomes a little more credible information. Now, the third is shared governance, where I was talking about the data governance part of it. I think that is very important, and it's not just hospital clinician. There is AI committee which should constitute of data scientists, clinicians, of course, and ethics committee, ethics members, which can really guide the shared governance structure. And I can give you a best example, if I'm not wrong, getting right hospital name. It's in Sweden, Karolinska.
Yeah, Karolinska, yes, yeah. It is. It's one
University
of the top
hospital.
10, yes,
yeah, exactly.
in the world.
So they have a platform which is called as QI agents. So what it does is, it throws all the genetic details, enters with the lab information, imaging information, and it throws out the treatment plan.
Yeah.
And they have implemented in 2022, if I'm not wrong, that a pediatric onco case was brought in, and they have put the data, and now what they have also done is any pediatric onco cases is a treatment plan is a complete wholesome genome sequence is must. So it's a part of a protocol.
Yeah. We're not there yet, by the way, here. It's just in Sweden, yeah.
So once that is done, I think, they have put this data into QI agent, and they have been told to do a treatment plan. AI has generated it. And the best part was it had a peer review journal which was also referenced. So that gave a confidence to the clinicians to take the action, and patient outcome was far better.
Was it better?
Yes.
That's interesting, yeah.
Yeah, and I will add for Dr. Manoj that we need the AI in the personalized medicine to be equal, not like a base. I think we have to start with the four things. Firstly, the data diversity. So to make sure that all is covering with the people population. Secondly, governance and transparency, which is really important, and continue monitoring for this data. Lastly, the privacy, where is most important for patients to have the AI privacy there.
Yeah. Any other additional insights from you? Yeah.
Well, I am really worried about the healthcare systems around the world. The NHS is crumbling, and I think that happens the same with most countries. Yesterday in Spain, all doctors were on a strike. So I am really, really worried about that. But I am very optimistic about artificial intelligence because it can spread the facilities to make possible equality in the deliveries of the best care for each patient. Actually, I teach students, and I show them how to use the artificial intelligence, for instance, ChatGPT. And if you change the age of the patient or the gender, everything changes. The treatment plan completely changes. Only one word. Obviously, if you add another condition or many comorbidities, it's completely different. So it can be helpful, but we, all doctors, will need to learn again from the basics: pathophysiology, pharmacology, understand the problems and the communication with the patient. This is indispensable.
Absolutely. And I think no matter what we do with our AI agents, that human factor is priceless and cannot be replaced, I think, unfortunately, by systems.
So can I just add one more point? I was giving you an example of Sweden Hospital,
yes.
So they had a tumor committee to really execute this program for that pediatric oncology. So it's not that they have just taken the AI, whatever the recommendation came, and there was a thorough understanding how it was done. And I totally agree with you saying that human in loop is a very, very important factor. you cannot remove that from the equation.
Absolutely. And I think one of the things I always say, so there's obviously this fear of AI taking over, especially in fields like radiology and pathology and so on and so forth. But at least from I don't think it's partnering up with AI, understanding how it can help you go through higher volumes with a much higher diagnostic yield and accuracy. And I think today, what's happening in at least my clinic, I'm sitting 60% of my time trying to annotate the notes and the progress notes of the patient, and not really look at the patient or interact with them. But if you have ambient AI, for instance, that can help you transcribe, work with you on your plans, then you can actually offer that patient that additional interaction, human interaction, which is extremely important. So what doctor said earlier on about if you're not comfortable with your doctor, then you need to seek another doctor. I totally agree with that, because, you know, feeling comfortable with your care provider is a huge component of the treatment plan as well.
And they already got well, just talking to you.
Just talking
before
to you.
The medication was
Absolutely,
given.
absolutely, because they feel that trust, and so that is much stronger than a placebo that you can offer these patients. So, I mean, in terms of the privacy and confidentiality that Dr. Talal spoke about and ethical dilemmas, personalized medicine relies heavily on data diversity, right? And so what safeguards need to be there to make sure that AI does not produce biases and prejudices? And it will be very interesting because we have in the panel esteemed panelists from, you know, dealing with different continents with very diverse populations. And then myself and Dr. Talal are from, you know, we're working in Saudi Arabia where the population is rather homogeneous. So my question is, you know, sort of what safeguards are there to make sure that these AI models don't have these inherent biases?
I think one of the most important factor is sampling. I think when you are trying to create AI, say, as I was talking about the biological layer and you have the information, what are the sampling techniques you're going to use? If you're talking about, let's take from England, you have so diverse information because the data is different kind of country, people will come.
Yes.
So you won't get that kind of, it will be more of a generalized information which is there. Then comes, if I compare with GCC, you know, you will think that it's a homogeneous because it's pretty straightforward. It is not.
Yeah.
Because, you know, there are something called as founders mutation, you know,
Absolutely.
well aware of that. And then the challenge comes, you cannot generalize the GCC itself. It has to be localized. You know, that will make more value. And one of the things which is, I think 2012, there is something called as Qatar Biobank. They started doing this. In Saudi
is doing
UAE
that as
have
well.
started this. And that is, localization is something very important. Now, biases, when you say, how are you taking a sampling? When you have a majority of population, you need to reduce that and increase the minority so that the biases can be reduced drastically. And of course, the same data governance and all that has to be taken care. Now, if you combine these two data, I'm just giving an example like from the England and GCC. From England, if you're taking a data set, you're going to get the breadth of information. But if you take the GCC and add this, you will get the depth. So if you try to...
Now I got it, yes, okay.
So because if you try to take the data set of UK and just run the samples of our data set, the system will label it, genes are having problem. because that is not there in the data set. So if you combine that and do it, you will have more precise results. So biases will be there. It has to be controlled. And even before the study starts, pre-deployment biases has to be defined in AI model. Yeah. And that is something, it's not happening to that extent.
So you need to question your assumptions, you need to question all of that, and the more data variables that you introduce, the better it is. Now, with you, Prof. Carlos, you're practicing, again, in multiple different continents, and that's why we're very much intrigued. Are you pooling all of your data in one data sets, or do you have them siloed?
Well, we need to be compliant with the law, okay. So it depends. I work for the equivalent to the NHS, La Seguridad Social in Spain, for the hospitals. Yeah. I work privately there, but offering the services to the...
so you need to silo them then?
Exactly.
Oh, okay. Yeah.
So yes. One of the most interesting, talking about England, the most interesting papers I have ever read is when they compare the life expectancy, mortality, and morbidity from one underground station to the next.
To the next underground station, next. Absolutely.
And it's not only genetics, it's not only...
social determinants of health, absolutely. Social determinants of health is a huge component. So, yeah, you know, with Talal and Dr. Talal and myself, we're working as part of Vision 2030, and our aim is by 2030, the life expectancy in Saudi is increased to 80, and it was about 70 in 2015, 2016. We've reached to 77, but what we've realized, although we've taken this initiative upon ourselves as healthcare providers, that healthcare contributes only 20% to the life expectancy. The rest has to do with how you eat, where you live, what's your education level. Social determinants of health are absolutely core components, and they also feed into, you know, genomics are a part of it, but it's also, it's also how you live, and your lifestyle is a huge, huge component of that.
Absolutely. I think I'll just add a point. You know, socioeconomic is also an important factor. Suppose a patient is having asthma, and patient lives in a populated area.
Absolutely.
Pollution is there. You know, any kind of personalized medicine will not work.
Absolutely.
Or take an individual who has got a lot of mental stress because of the financial constraints. AI cannot come out with a personalized thing. So there is a component of socioeconomic factor, which is a very important factor to really get into this personalized medicine.
Absolutely. And do you think, Dr. Talal, the AI are we using it enough when it comes down to, as part of our healthcare transformation? Are we leveraging innovation and AI today as part of Vision 2030, you know, within the health clusters and the ecosystems?
Yeah, absolutely. AI is coming as a precious measure in the future. And we believe that one. But sometimes it came as a burden for the physicians or the patient. However, in our Saudi's Vision 2030, if we're looking for the AI to become close to the patients, to have good treatment. For example, Dr. Maryam, in our Eastern Health Cluster, we have the AI working well with some of the rural area. We have we have some central hospital, which they are far away from the region, but we can serve by expert surgeon to follow up with the patient using by AI now. Yeah. So ICU patient, for example, they are following as a daily during the AI, even ER patient, when they are in the region. Sometimes they are a small hospital, but we are referring the AI by connected with the tertiary or central hospital in Saudi. So they will have a good experience between both surgeon or both physician to come up with the good treatment. We still not reach the fully competent with the AI, but I believe in the future AI will be the best thing to help the patient and to give a great service for our customer.
Yeah.
I just want to add a point here. What is happening with AI is totally focused, saying that this will do everything. But instead of that, if AI becomes a part of a process, and that doesn't give a burden to clinician or a patient for that matter, I think that is the differentiating factor which has to happen. But everyone talks about AI, and it's, don't get me wrong, because a lot of time AI is used very loosely.
Absolutely.
It's machine learning is also AI. You know, NLP is also AI.
Yeah,
so I
LLM,
think,
yeah.
so what happens is, I think nobody is looking at the process. Our objective of AI should be how the life of the stakeholder is becoming little easier. Exactly.
Yeah.
And that is only possible if this entire system, without any changes, it should be part of the workflow.
Absolutely. And I think what we need to do going forward is to innovate around that exactly. So for instance, what Dr. Talal was mentioning is how can we leverage that to today within our healthcare cluster, himself and I are working in the same ecosystem. It's about 146 facilities. So you have 22 hospitals, 120 primary healthcare centers, over 500 kilometers of land. Some of them are in areas in the middle of literally nowhere. I visited them. There are no roads, minimal amenities and facilities. So how do you leverage the systems to allow equity of care and to make lives easier for people rather than them coming to you? You can still deliver the right caliber of care, even from a distance. So I know we're coming to time. I have a last question, and it's rather maybe controversial slightly and challenging. And my question is for all three panelists, but also I would like to hear from the audience if anyone is interested to answer. So if AI becomes more accurate than clinicians in predicting treatment outcomes, should the final decision in personalized medicine rest with the algorithm, with the physician, or with the patient? So I'll start with you, Prof. Carlos.
Thank you. It's a wonderful question and follows the last one that you told me. That's why we created sleep care clinics in different places, because sleep medicine must be available, accessible everywhere, not in London. If it is needed at home in Valencia. So, and that's, your question was, can we pull the data in the same place for? No, we can't. It's impossible. We need to focus on the legal aspect of each country, and we cannot use the same template to provide the diagnosis, the same apnea-hypopnea index here in London or in Caracas. It changes, and the decision must be a link, the professional link with the patient and the doctor. And this is indispensable. We don't learn much about that elsewhere in Venezuela or in Spain, but ideas, concerns, and expectations that we learn in England is very, very important, because maybe that's the only way that the same treatment could work or not in a patient, depending on what they want.
Depending on what the patient wants. So that's very clear. Yourself, Dr. Manoj?
I think human in loop is very important. It's not going to happen, not for at least 2 decades. That's what my prediction. I might be wrong. But every information, the decision, and when you talk about human, I think you cannot leave it to the algorithm to decide what is good and what is bad. It has to be a human. And even now, tomorrow, there are so many devices which are there, which will do a self-check and all that. But still, patient wants to have a discussion with the doctor.
With the physician.
And that face-to-face and touch and discussion is an important factor between the patient and doctor for a better outcome. So it is never going to happen where the patient is, will treat himself by algorithm, which is not going to be happening. And of course, the digital thing, the information which we are going to provide to the providers or doctors, it will really help to take care of the patient well and for a better outcome. That's how I foresee the future of personalized medicine.
Perfect. And with you?
I think if AI become as accurate than clinical, it should be decision among three, AI, physician, and patient, as we need augmented clinical judgment. So it's important for those three types to be in the final decision, not only AI.
Perfect. Anyone from the audience interested? Yes, please. The far back, and then after that, it's His Excellency Dr. Riyadh as well. So just still here. Yeah.
Thank you very much. It was wonderful, really. I just wanted to add one comment on your last question, which can be a little bit reframed. It's not only a question, are the humans as a patient important, but also a doctor as a human being, because we had some pilots in Switzerland where doctor was excluded as a physical person, real person, and replaced by algorithm. And then there was a pure interaction between physical patient and algorithm, and people were very, very unhappy. They really want to talk to the doctor, to the human being, not to some screen and algorithm. And regardless of the accuracy, because accuracy was actually very good and the outcome of the treatment was good, but people were feeling very unhappy and they still wanted that the doctor tell them the diagnose or to ask them a question and talk to them. They need this human interaction. And that is, I think, the point which we cannot neglect. And second comment, which is important, which was not touched in this discussion, it's no matter how well you design your experiment or choose your population or treat your data or handle your data, there is still one point which is critical, and that is a language model on which you base your AI model. So you can build perfect model, but the language on which is used beneath is quite important. That was recently one experiment in Geneva. It was financed and organized by Healthcare Department of United Nations, and they find out that based on the open and large language models, you cannot build reliable systems which are usable either in healthcare or in science. So they started a quite comprehensive work on designing special closed language models which are going to be targeted and pull out the language base only from the scientifically reliable data.
Yeah. One rebuttal, and then we'll give the mic to His Excellency Dr.
Thank you.
Riyadh.
Yeah, so I agree to a great extent what you said, but it's not generative AI now. The way the knowledge is going, it's called as a knowledge agentic framework. So what we have to do is we have to define the boundaries with what the data is going to be. So if you don't define it, it is going to hallucinate. So the way the dynamics are changing is you need the data to really define the boundaries. Only from that boundary you need to get the answers. So that is one. The second point I think you raised about governance and data, right? So every country has got, when you go to the Europe, GDPR is there. And when from the US point of view, you have a HIPAA. Now, there are standards. Now, if you come to GCC, we are a little more advanced in the way because we have something called as HIE, Health Information Exchange. So entire data sits over there, and it's just a transportation of data from clinic or hospital. So that is, yes, privacy is a very important factor, but there are laws which is there and which has been taken care of. So yeah. That's
so we have a comment from His Excellency, Dr. Riyad.
Thank you very much. Riyad Najm from Saudi Arabia. It's a very interesting question that you raised, Dr. Maryam. Who takes the final decision?
Yeah.
The doctor or the medical doctor, the AI, or
the patient?
The patient, yes. But don't you think that there will be levels of taking decisions, maybe based on the sensitivity and the seriousness of the matter? Yeah. So probably you'll say, in case A, it is going to be the AI. Case B, it's going to be the medical doctor. And C, it's going to be a combination between the medical doctor and the patient. So, and I'm sure this is going to take place one day or the other. Things are going that way, and some of the decisions will be taken by AI if they are not serious. Yeah. And I fully respect the opinion of Dr. Manoj that it's going to take 15, 20 years. I think it will be much less than that.
Shorter.
Much shorter.
Yeah,
thank you.
I'll give you an interesting example. Maybe the most relevant example of personalized medicine would be oncology because of the genetics and all this. On the other hand, one of the most difficult doctors to replace or professions to be replaced are oncologists. So you can see, this is the future, is here now, and we are indispensable, our clinicians.
Yeah.
So just to answer your question, I'm not talking from the technology point of view. You might have, now the ChatGPT-5, they say it's a PhD level. I'm talking much more than that. Now, if you talk about genomic tests, there was a time where it was costing around $10,000. Now, if you do, I think from US, if you are coming, you know 123Me, say around $1,000, and it'll take time. So getting into that commercial multi-omics array profiling is what is going to take time. I'm talking from the reference of personalized medicine. It will be there, not to the extent where it could be available commercially. Yes, all this is happening at the government level, but it's going to take quite a longer time. Yeah. That's what I meant by that.
Yeah. I see a lot of hands up, but we're sort of short of time, so maybe we'll leave the questions later on with the panelists. Yes, we have 3 hands up. Yes,
thank you.
Yeah. Okay. Yes.
Just short response or commentary. So, because I find the question very interesting about the final decision between physician, patient, or AI. Today, we talk a lot about AI, artificial intelligence, and I think that they will be complementary. Doctor, physician, and AI to help and to be serving to the patient. In all cases, I think that patient needs the perception of physician as a human being.
Absolutely.
Exactly. And the doctor, physician needs also the help of AI to have more precise information about the final decision. So the key word is complementary between the third.
I totally agree. I think the 3 components, like what also His Excellency Dr. Riyad mentioned, the 3 components are not mutually exclusive. They're all part of a spectrum, and I think there needs to be a conversation between the patient and the physician, and an assessment of the algorithms that have been inbuilt to personalize that, questioning the assumptions that are there, looking at the rationale, what's happening behind the scenes to produce the results. So let's say the AI says this is how you should treat it, and I think I should treat the patient that way. I need to understand the reasoning behind that, and then really have a conversation between all three elements, the patient, the algorithm, and the physician themselves, and then you can come up with a... So I think, to be honest, it was a tricky question, and I don't think there is a single component or an answer. I think it's more of a continuum of all.
And also the patient
need
the empathy and the listening of the doctor.
Absolutely.
Yes, thank you very much.
Yeah, thank you very much. And I think this is what I'm really looking forward to when we have ambient AI, that I actually can remove the device and look at the patients and enjoy a good conversation with my patients, to be honest. I keep on moving the device in the clinic further to the left so that I have more, but you can do so much, but it's really, having that conversation. I deal with very chronically ill patients, so really having that rapport with the patients helps go a long way, helps credibility, and helps with them taking care of themselves.
And
so the final question,
just
go ahead.
Points that to make it clear, not conflict. The AI will help just to inform the information.
Yeah.
It's not only making decision.
Yeah. Last question.
Yeah. So first of all, very wonderful question. I, being an AI enthusiast, we are working with the largest players of the world in creating a uniform system for the nurses and doctors, recruitment, training, and end-to-end. I just wanted to say in a very brief that the information or the last mile thing should always be remained with the doctors. AI is just a supporting system.
The doctor and the patient.
Doctors and the patients,
yes.
absolutely. AI is just complementing and supplementing the work and giving the uniform decisions that out of the 10, maybe these 2 can be chosen. But end of the day, it's the doctors, it's the patients. Yeah. So undoubtedly, it should be lies with the human. And there's a wonderful proverb said by a very big consulting firm recently, care cannot be replaced by AI.
Yeah.
Thank you.
Okay. I've been told we can take one more question, so there are too many hands up.
Interesting topic, huh?
Yes, I'm intrigued. So thank you very much for your participation.
Actually, I do agree about the personalized care and the right doctor when we say so, and AI. But to me, I think personalized care has to speak also about being the right doctor with the right skill. Actually, a nurse by profession, but now I'm already into the sales field of healthcare. So I'm in the middle between the healthcare and the business industry. And I feel that somehow what would hurt personalized care is healthcare turning into being a business. I'm in orthopedics. So in orthopedics, there's a lot of specializations. There's foot and ankle, there's knee, and there's hips, and all these. However, because of business, there are doctors who are forced to do what they are not entirely trained to do. And what is my fear is when AI comes in and it becomes like, okay, I can do it because there's AI. So I believe that we should, or hopefully, there will be laws that will define what is personalized care, really, in terms of specialty. Because I think there's a loophole in that point at this time, that everyone gets to do anything. Yeah, because it's like, I've seen that. I'm there.
Absolutely.
That's why I'm an advocate because I bring implants for foot and ankle, so I don't just generally give it to everybody, even so it's a business for me. Because I still believe that there's the right doctor with the right patient to do it. So we just have to have that law to say what is really personalized care with AI.
Yeah, and I think that's a beautiful way to sort of wrap this session up. Personalized healthcare is here now. However, I think we need to shy away from putting AI as front and center of everything, but rather a true partner with the physicians the healthcare providers, not only the physicians, the nurses, the allied health, and also with the patient to really augment and accelerate and improve their healthcare to the best levels. It is as good as the users, it's as good as the information we provided with, and it's as good as the algorithms that we feed it. We need to always assess it. So I think, yes, we're here, and there's a long way to go. But I think, again, this misnomer that artificial intelligence is the solution or it is the end is something that needs to be completely wiped out, I think. It is a vehicle, it is a way to accelerate healthcare, and it is a partner. It's not going to be replacing humans. It will be replacing some of the jobs for sure. But new jobs will be created, right? So I think that's what we do. I hope you all agree with that. Yes, and with that, thank you so much for your active participation. And if you have any, oh, there is one more question. Yes, go ahead.
Sorry, I'll be very quick.
Yes, no, thank you very much for your participation.
This is a very broad question, and that you asked, and particularly when we talk about personalized medicine, and when we talk about digital twin, I think really the answer to your question is it's all of the above. The patient will be informed, especially in terms of their health, because we as a nation are empowering patients to take more accountability of their health.
Absolutely.
Healthcare professionals are definitely going to be involved, but they're going to be aided by AI to make better informed decisions. The fact of the matter is that technology used to be an enabler, but now technology is a necessity. Likewise, AI is currently an enabler, but designed well, served well, it will become a necessity. However, in a way that will help us make better decisions as patients and as healthcare professionals. The other point that I wanted to also add is we talked about patients, we talked about AI, we talked about healthcare professionals, but we mustn't forget the regulators, the policymakers, because really, AI, what is AI? Where does AI get its information from? It's all about data. So having right amount of data, Dr. Manoj mentioned HIE as an example, having right meaningful use of data, controlled, governed, and enabled in the right way, these are driven by the policymakers. These are driven by nations, not necessarily doctors or patients.
Absolutely.
So I think that's very important for us to be able to make sure that we add that to the mix.
Very important comment. And I think, unfortunately, we were just discussing this around the table. The policymakers and the regulations in certain countries lag behind. Because of the governance and the bureaucracy, sometimes it takes longer, but other countries, they're very forward-thinking and way ahead of their time. So we need to kind of be keeping up with the pace. You agree with that? Yeah. So with that, that's a wrap. Thank you so much for your participation and your time, and we'll see you soon. Thanks.
Apnoia.